Our topic today in the ground glass pattern part 7 will be focused on one entity. Before we start, I'd like if you can scan the QR code because we will use it several times during this session. I think you are done with this scan for the QR code. In the previous sessions of the ground glass pattern, the first was discussing the ground glass pattern in general. It was like introductory to the other sessions. Then we discussed the acute ground glass opacities. We discussed also the chronic peripheral ground glass opacities. Then today will be the first time to discuss the central or diffuse ground glass pattern. And at the top of the differential diagnosis is the hypersensitivity pneumonitis, which is a common entity encountered in clinical practice for pulmonologists and radiologists. And these are the remaining differentials under this central or diffuse ground glass, chronic ground glass pattern, but we cannot discuss something beside hypersensitivity pneumonitis. And I hope also we can discuss the whole thing regarding HP in today's session. In the beginning, the definition of hypersensitivity pneumonitis, it's an immune-mediated disease triggered by inhaled antigens. And it affects the interstitium and small airway disease. Therefore, it is mixed infiltrative and obstructive disorder. This dual involvement explains the characteristic high-resolution findings. Here, in this diagram, the bronchus beside the bronchiole, beside the arteriole, and this is the cross-section of the bronchiole in the normal lung, and they terminate both arteriole and bronchiole at the center of the pulmonary lobule, and this is the interlobular septa. When inhaled, when the small organ particles are inhaled within the bronchi, it will induce three mechanisms. First thing, inflammation around the bronchiole. This bronchiole, there will be inflammation around it, producing the centrilobular ground glass nodules. When this inflammation causes narrowing of the lumen, of the bronchiole, it will produce the Mosaic attenuation and inspiration. And on expiration, we will see that there is air trapping. In case of spread of the inflammation into the interstitium, it will cause ground glass opacities. Combination of these two mechanisms in one patient will produce what is called 3-density sign. So why it is mixed infiltrative obstructive lung disease? Because of the HP pathogenesis. Here, this bronchiolocentric inflammation and small airway disease, small airway obstruction will induce the small airway disease part component of HP, producing centrilobular ground glass nodules and mosaic attenuation and air trapping. The infiltrative component, it will happen when interstitium of the lung is involved with inflammation producing ground glass opacities. That's why, because of this pathogenesis and because of its mixed small airway disease and interstitial disease, it is crossing multiple high-resolution patterns. That's why we discussed HP, hypersensitivity pneumonitis, in the nodular pattern session. Today, we will discuss it in the ground glass, chronic ground glass pattern session, and we will discuss again in the Mosaic pattern session because of this bronchial obstruction pathogenesis producing mosaic attenuation and air trapping, and we will discuss that in details with the differential diagnosis at that time. So why we are discussing HP in the chronic ground glass opacity session? Because commonly presents with persistent ground glass opacities, either centrilobar nodules or ground glass opacities. And the current hypersensitivity pneumonitis classification is based on the presence or absence of fibrosis, not disease duration. So the key high-resolution features of hypersensitivity pneumonitis, we have the three main features: centrilobar ground glass nodules, ground glass patchy or diffuse, and lobular mosaic attenuation. It is lobular because it is due to small airway disease. The vascular disease will cause non-lobular mosaic attenuation, and we will discuss this in the mosaic pattern. Combination of ground glass opacities and lobular mosaic attenuation will produce the 3 density sign, in addition to presence or absence of fibrosis. These are the key features of hypersensitivity pneumonitis. So here I will show you illustrations of these findings before discussing the classification. This is the appearance of the centrilobar ground glass nodules. And now, after discussing the nodular pattern in the session concerning nodular pattern appearance, now we know this is centrilobar distribution. No nodules along the fissure or the costal surface. They are evenly distributed from each other. And this is logic because they are involving at the center of pulmonary lobules, so they will be evenly spaced from each other. And even if they are in clusters or grouped, so they will be also evenly distributed from each other, like here. And this region is spared. This is another region spared, but they will also follow that they are at the center of pulmonary lobules. Here, the other feature, which is ground glass opacities diffuse or patchy. Then the mosaic attenuation that you see heterogeneous lung and homogeneous lung. The pathology here is the low attenuation regions, which are subtle here with lobular appearance. In expiration, it will accentuate the difference between the normal lung, which it will be whiter, and the black areas will keep its density low, and the difference will increase between the normal lung and the diseased air-trapped lung. Combination of ground glass opacities and air trapping or mosaic attenuation, in addition to normal lung, will produce the 3 density sign. The previous classification of hypersensitivity pneumonitis was based on the clinical course and disease duration. It was classified into acute, subacute, and chronic, and this is obsolete now. And the current classification is based on the presence or absence of fibrosis. Thus, HP, the main 2 categories are fibrotic HP and non-fibrotic HP. This classification is established by 2 organizations or societies. Sorry. We have first in 2020, we have the American Thoracic Society, Japanese Respiratory Society, and American Latin Thoracic Association. These societies established a classification in 2020. Then after 1 year, followed by the CHEST, which is the official journal of the American College of Chest Physicians, ACCP, produced another classification different from the classification of ATS and other societies in the details under the same classification. We will see now that. So in 2021 was later to the 2020 American Thoracic Society and other societies classification, both chest. This is the logo of the chest, the Journal of American College of Chest Physicians. And here we have the American Thoracic Society, Japanese Respiratory Society, and American Latin Thoracic Association. They are both the same, categorizing hypersensitivity pneumonitis into fibrotic HP and non-fibrotic HP. Under non-fibrotic HP, they are subcategorized into two subtypes, typical and compatible with HP. Fibrotic HP is the same, and they added the third subtype, which is indeterminate for HP, because it's only showing fibrosis, no features of hypersensitivity pneumonitis, which we discussed and we saw some examples of them. So before we proceed, I just like to ask you this question. I know we are having here pulmonologists and radiologists, and the majority are consultants and specialists. And I'd like to ask this question before proceeding. If you are applying any of these classifications in your clinical practice or MD teams, multidisciplinary discussions, are you applying the American Thoracic Society or chest or both, or not routinely used as HP classification? I got two answers. I wish to get more, and I want the honest answers regarding this. I don't routinely use an HP classification, and this is what I expected to know, because let's complete. Okay, let's proceed to next.